to all of you who have joined and who has taken time out for this particular webinar. This webinar is special and holds a very close place to our heart because this is about GC awareness. And when we talk about rare diseases, GCs, the genetic counselors, have a huge role ahead. And I first would be grateful and thankful to all my fellow colleagues who has accepted to moderate these sessions. We wanted to show the length and breadth of what a GC can do, and also all the healthcare professionals who have joined and given their time to us for this particular session. I know it's from 4 o'clock and it's very difficult. It's in the middle of an OPD, but my sincere thanks to every one of them. And all of these people have been so supportive of GCs in India that, we all of them deserve a very good clap from all of the GCs. It's also Thanksgiving few days later, and we really are grateful to all of you. I introduce my wonderful moderators for today, without whom we wouldn't be able to go ahead with the session. We have Nirja, who will be taking care of the reproductive health part, followed by me, who would be taking care of the fetal medicine part. And then we have Gayatri, who will be dealing with GCs in pediatrics. And then we have Deepa and Madhvi, who will be dealing with just hemoglobinopathies, because that's a huge area where GCs can contribute. Then we have a very interesting session by Nibi, who will be talking on often ignored topic of adult rare genetic disorders and the role of GCs in that. And then we have a very sensational session of tumor boards and GCs with Dr. Aparna Dhar. So with that, I leave you and I leave it to Nirja to start off the session, and immensely thankful and grateful for you to join this session.
Thank you so much, Pranjana, and thanks for organizing this wonderful webinar, and thanks to ORDI for letting us, take this opportunity. So I would first love to introduce my panelists. Just give me a second, I'll share my screen. So it's a pleasure and honor for me to have three wonderful panelists with me on board today. These panelists have also been a close mentor and have also been colleagues. Firstly, I'd love to introduce Dr. Divya Agarwal. She is a senior consultant in medical genetics in Apollo Indraprastha Hospital. I then have Nibi, who's the founder of Blue Gene and a very dear colleague, and she's been setting very high standards in genetic counseling for the last 15 years. And I have Dr. Pratima Radhakrishnan, who's a pioneer in fetal medicine, and she's the foundation director of the Bangalore Fetal Medicine Center. So thank you for all taking us the time today to be here. This is just an absolute pleasure for me. So I'm going to begin with, my topic today was to talk about navigating the roadmap to reproductive health. And so I have a few, concerns and questions that I posted to all the panelists that we'll go through. And this is really to talk about how genetics plays a role in reproductive health. So I first want to discuss a few questions on, appropriate ways to offer tests at various stages of conception. Dr. Divya, I'll open the first one to you. This is about, most of the couples nowadays are very well informed, thanks to advances in AI and Google, and many of them come well read and talk about having some sort of genetic testing prior to conception. So as an average Indian couple, what would your recommendations be when there is no significant or red flags in personal or family history? And then the follow-up to that is, would you recommend doing DMD and Fragile for everyone? So this is something that a lot of us have been debating about. Over to you, Dr. Divya.
Thank you very much, Nirja, and the ORDI team for having me on the panel. And thank you very much for a very important discussion on the reproductive genetics. So yes, I mean, this is a very common scenario that we do have in the OPDs, where the couples now want to be informed more. They are reading much more, and they want to be informed more about the genetic risk in their offspring. So there are various recommendations that have been given by the American board, by the European board, and now the Indian Academy of Medical Genetics also has given some recommendations with regards to the testing of the couples genetically to assess the risk of having a genetic problem in their offspring. Every country or every region, it is important to know which genetic conditions are particularly common in our own populations, and hence it is important to have our own recommendations. The conditions in an American or a Caucasian population, genetically, since they are so different, there are some common genetic mutations that would run in them, and hence the conditions that are commoner here in the Indian population might be very different. So what we know of in India is that certain recessive conditions like thalassemia, spinal muscular atrophy have the carrier frequency more commonly in the general population, which means that we are more likely to be carriers of these kind of recessive problems like thalassemia and spinal muscular atrophy. The carrier frequency is as high as 1 in 30 for SMA to 1 in 4 and 1 in 3 or 3 in 100 for say thalassemia. So for these common genetic conditions, it is now recommended that all the couples who are planning pregnancy be tested for these conditions. Then there is an expanded carrier screening that can also be done, which tests for all the recessive genetic conditions in the couples. And the couple can get tested for a whole set of genetic conditions apart from these common genetic conditions. However, such kind of expanded carrier testing is recommended to be done only in the presence of indicative or suspicious family history, or in case of any other high risk factors like consanguinity or bad obstetric history, or a previous child with a suspected genetic problem, or a family member with a suspected genetic problem. Ideally, in those cases, then we would want to assess the affected person first and then go ahead and do the testing for the couple to be able to tell their risk of having the condition in their offspring. So overall, in a nutshell, thalassemia screening and SMA screening is what we recommend now for all couples. An expanded carrier screening for some other genetic recessive conditions can be done, but it is usually done in cases where some other high risk factors are also present. And it definitely needs to be done only after consultation with a geneticist or a genetic counselor who can actually assess the risk properly and let the family know about what the test is for, what are the limitations of the test, and things like that. The second question, whether, is it appropriate to test for DMD and Fragile X in every couple? Now, Duchenne muscular dystrophy and Fragile X are also common genetic disorders, are one of the commoner genetic disorders. However, their carrier frequency has not been found to be as high as for thalassemia or SMA, or in a range where a population screening can be suggested. So although these conditions can be screened for in any lady who is planning for a pregnancy, since these are X-linked disorders and we just need to screen the mother or the potential mother for these conditions. However, it is still not recommended that we screen all the women for Duchenne musculars or for Fragile X at a population basis. Of course, if there is a history suspected to be, running in the family, which suggests an X-linked inheritance, which means that, it's coming from the mother's side and only males are affected. So only after consultation with a geneticist, genetic counselor, testing for DMD or Fragile X in a family, in a suggestive family history scenario is what we would recommend.
Thank you. Thank you, Dr. Divya, for giving us more insights on this particular concern. Dr. Pratima, the next scenario is really for us to understand. We get a lot of cases in the clinic where we see that there is a high-risk pregnancy and that the initial, maternal serum screening has come back to be abnormal. Many of these parents are now concerned, especially when it's a precious pregnancy. They're concerned about undergoing an invasive procedure due to the fear of complications and end up using an NIPT, however, NIPT being a screening test. So what is your take on this? How do you counsel, or what are your suggestions to these couples who are concerned about the risk of invasive procedure, and how would you approach it?
Well, NIPT is good and bad, both. And to be very honest, currently, I think in my own practice, at least I can say, high risk NIPT or a no call NIPT is the most common indication for actually doing an amniocentesis, right? Because NIPT, the selection of cases where NIPT should be offered is very random. And anything and everything, NIPT seems to be the panacea for everything. And that is not right at all. And no wonder I'm getting so many. In fact, today also, I was scanning a lady who was referred to us with high-risk NIPT for sex chromosome. And we were not even looking for it. It was done for hypoplastic nasal bone, which was not actually hypoplastic. It was fine. But because there was a discrepancy in two reports, she was told to just do NIPT because just in case. And then she did NIPT, and that's come high risk for sex chromosome. And she said, no, we were not even looking for that. Why? So then, of course, that set off a whole lot of checks and balances. And finally, they decided not to do the invasive test, right? Which I think is the right decision for them. But anyway, many people end up doing invasive tests and end up terminating a pregnancy which could have otherwise been normal and just had some fertility issues. The other big challenge with NIPT being done randomly is people are terminating based just on a high-risk NIPT result, right? Some slight marker on the scan, and then NIPT. We must remember that NIPT, the technology has been in clinical practice only for the last 15 years, whereas, of course, it's been in the laboratories, whereas scans and the knowledge about the scans has been around for much, much longer time. So realistically, NIPT no way can replace a good scan. No way can replace a good scan. The second thing is we're talking about risk of miscarriage. What is the risk of miscarriage? The risk of miscarriage is 1 in 300 to 1 in 500, which is like 0.2% to 0.3%, which is extremely low, right? That risk we take at least 10 times more that risk we take just crossing a road in Bangalore, right? Walking on the road, we take much higher risks, right? We have to weigh the risk of doing the procedure not against nothing. It has to be weighed against the possibility of having a child with Down syndrome, because if you don't do the invasive test, that's the result in the worst case scenario. So you cannot weigh the balance of risk of miscarriage to nothing, right? The risk of miscarriage is versus the risk of having a baby with Down syndrome. Those two things need to be compared. And when the risk of Down syndrome or any chromosomal or genetic problem for that matter exceeds the risk of doing the procedure, then of course, common sense, you have to do the procedure, right? There is no, NIPT cannot replace. It is not there to replace. In fact, it's causing more trouble than goodness, primarily because the indications for NIPT is very soft and very random. If you choose your NIPT correctly, for those with intermediate risk, the structure of the baby is otherwise normal. We don't have any major markers because clearly, for example, the ACOG recommendations for absent nasal bone, aberrant right subclavian artery, for ventriculomegaly and for nuchal edema clearly says NIPT does not suffice. And still the commonest reason why people doing NIPT is absent nasal bone or hypoplastic nasal bone. So it's a challenge. The other problem with NIPT is the laboratories. The laboratories, we have no idea what technology they are using in the background. Majority of them are outsourcing in the background. right? So we have no idea where the tests are being done actually and how much you can rely on the test. Just writing it on the report and giving a 10-page NIPT report where only literally half a page only is relevant doesn't make sense at all, right? So again, to the extent that one can actually now predict which laboratory you're going to get a high risk from, right? We have kind of reached that point. So I think we have to be extremely careful, one, when recommending an NIPT, two, the laboratories you choose to do the NIPT, because the implications of a high risk NIPT and a no call NIPT is significant. And if you do your NIPT correctly for the right indications, then the accuracy is as high as 99%. But if you don't do it correctly, then it is going to have problems. So that is what our data shows as well. So I think, does that answer all your question, or have I left out something?
No, these were actually very, very good insights. Thank you so much. And, I think it really helps to put things in perspective for other genetic counselors who are listening here as well. So I'll take the next question, and since we will be running short of time because there are other panelists as well, we'll try to keep these brief. So the next one, Dr. Divya, again, this is back to you. This is a very common scenario we get in the clinic where a family has lost a previous child or there's a suspected genetic condition, but no testing was done. And then the couple presents at, 5 weeks of pregnancy, or sometimes a little bit later, 20 weeks, or, essentially late in the end of the second trimester. So how does your counseling or recommendations for testing differ in both of these scenarios?
So as I said earlier that, a family who have lost, in a family with a suspected genetic condition, the affected child or the affected person needs to be tested. And Neerja, can you hear me? I think I'll
Yes,
keep
ma'am.
my, I think I will need to keep my video off because the internet connection seems to be. So the family member or the previous child in this case needed to be tested to be able to, get to the causative mutation. However, in the absence of that, we can test for the couple. We can test the couple to assess whether any recessive genetic mutations are present in them. And we try to correlate those genetic findings with the clinical history and with the clinical differentials that we make out of the history and out of the medical records that we collect for the previously affected child. So, genetic tests are, of course, unique, and they're not like, you just put in the blood sample and then a list of mutation comes up. These tests are, although automated, but the pipelines that give the results, the details and the clinical differentials need to be put into them for us to be able to get meaningful results. So the clinical part and the medical records and everything need to be recorded properly, and then the differentials need to be made, and then the lab needs to be notified that with the couple testing, we would want these genes to be probably screened in them. Now we know that, if the couple is found to be carrying a recessive gene, both the partners are found to be carriers, then there will be a risk in this pregnancy of the recurrence. And in such a scenario, prenatal testing can be recommended. Now, your question about how do we manage this at 5 weeks or 20 weeks? Usually, there is no one clear-cut answer to this. My approach would probably remain the same at both the gestations. However, if the suspected genetic condition in the previous child is, say, a Hunter disease, a mucopolysaccharidosis type 1, and I have plenty of medical records, even if the genetic test wasn't done, but I know that the most probable diagnosis was a mucopolysaccharidosis type 1, which is a clear-cut recessive condition. I would probably err on the side of, doing the couple testing and maybe offering the prenatal testing at the same time, because, we might be, here in this case, we are looking at a scenario of almost surety that we will find some mutations. But again, it is extremely tricky to do that, and I would definitely, not recommend doing that, especially by a non-geneticist. No, absolutely not. So for all practical purposes, for the clinicians, I mean, at the max, it has to be the couple testing that needs to be done, and the mutations need to be found. And the clinical correlation part is, again, it is extremely important, whether to be done in consultation with a genetic counselor or a geneticist.
Absolutely. Thank you so much, ma'am, for taking up that. I think these are pretty common. They come up quite often, and sometimes we also see them after the testing and is completed and with the reports in hand, which makes it much more difficult curing of pregnancy. So my next question, maybe this is for you. So this is again a scenario that a lot of us as genetic counselors come across where, unfortunately there are unexpected results. So here we have a case of a 16-week, pregnancy. Sanger testing was completed for a previously known mutation in the family in an affected kid. So it seemed very straightforward, but then unfortunately you didn't get the results in time for whatever reason. And this mom also had a history where her second pregnancy was at a time where she lost her first kid. Now she's, calling you anxiously, repeatedly calling you to get the results on the third pregnancy, on the fetal sample that was tested. So how do you handle this? What do you anticipate as a genetic counselor, and what's your input on?
Thanks, Neerja, for bringing this question up. I think for those of us who have been in clinical practice, we are not left unscathed by such situations. So first of all, I think by the time this woman would have been calling me, she would have been at 18 weeks at the very least. And so the minute I hear or I get a communication from the lab saying that we need to repeat the test, I think it's important to get clinical clarity and technical clarity on, is a repeat sampling required? Do they have sufficient samples? So was it a problem with the sample itself, quantity or quality, or was it to do with the test itself, first of all? Second, with respect to the patient, I think it is important to balance clinical accuracy against compassionate support in this situation. Given her previous experience and her lived experience in a situation, it's important to offer empathy. It's often necessary in such situations to validate their lived experiences and what this delay might mean for her. So I think more than the technical weight of the test result, it is important. This is more of an emotional weight for her. And so it's important to identify that. Of course, be transparent with the family or the couple about what has gone on. And it's very important to reassure them that this does not mean that there is a problem, but it means that currently we are not able to give an accurate test result. So it's very important to distinguish between the two and also offer them more time. Processing such a situation is not just wrapping their head around the technical aspects of it, but also understanding the timelines and what the outcomes might be and what their next steps might be. So, telling them what the timelines might be and also reassuring them that there would be more frequent check-ins and updates as and when we hear from the lab. So these situations, personally, I think as a genetic counselor, it is important to acknowledge the emotional impact such a situation has on a couple.
Thank you, Nidhi. And I think, again, they present a lot of challenges in a clinical setting, especially in genetic counseling for us. The next question, and I'll wrap up with one more question after this. Dr. Pratima, this is for you, and this might be very simplified, but really we see cases where we see inconclusive results due to MCC being positive and patients get very anxious. So what do you recommend in these cases? Do you ask them to repeat the invasive procedure? What's your approach? Ma'am, you're on mute.
We must understand that when we do a procedure, we are committed to giving an answer. We are absolutely committed to giving an answer. It doesn't happen very often that we get MCC positive. Maybe in my 20 years, I must have had probably a couple of occasions. And both the occasions, we told we called the parents back and we said that, look, we cannot rely on the results that we have got because it may be mixed and we are committed to giving you an answer and we must repeat the test. I mean, I don't think there's any two ways about it, right? We have to be, as Nibi said, we have to be honest about it and say that it is not reliable. And we have to do the test. And well, after that, if the couple agrees or disagrees, it's their choice. But most of the time, I don't see any reason why they disagree because it happens to us when we have a placental mosaicism and then we have to repeat with an amnio because they've already gone through a procedure once and they've been safe. So the confidence level for the second procedure is actually much higher, right? Provided we have maintained an open relationship with them right from the word go. I'm not saying after the second procedure, after the results, even from before doing the procedures, we have to have good relations on why, what, everything having answered. And it is, if we can't give a result, we need to try and work hard and make sure we give them a result because that's what they have come to you for. And particularly many of these DNA-based tests are genetic tests. I mean, there's no two ways about it.
Right. So rapport building becomes really important in that scenario.
Yes.
Absolutely. So Nidhi, my last question is for you again. So what's your take on, doing PGTM and or prenatal testing for adult onset conditions? I know you and I were talking about this earlier, and I'd love to hear everybody's thoughts also on that. Go ahead, Nidhi.
So I think this is something that is widely debated, especially here in India. There are clear guidelines, say in the US and in other countries, that talk about whether you can test for a specific adult onset condition or not. In India, where we do not have a very direct guideline, it can get quite tricky because sometimes it's based on the requests of the family or the couple or the patient themselves. Sometimes it is based on a request from, say, the primary care physician of the patient. So I think I personally take it on a case-to-case basis, identify, where this request is really coming from. Do they really understand the implications of identifying this information, what it would mean for the child? So giving information, anticipatory guidance is something that has helped in situations like this. Maneuvering patients in deciding whether they wanted to go ahead with prenatal testing for an adult onset condition or not. And I said it's tricky because, in cases of BRCA1, BRCA2, it's slightly easier, slightly straightforward. But in other adult onset conditions where in the family history we see anticipation, where there is a much earlier onset, a child presenting in the family with clinical features, it gets quite complicated then. And I think it is important to involve all the stakeholders, that is, including all of the medical specialists involved in the care, to come on board and to discuss these, what the outcomes might be. And then, of course, respect what the families would are expecting out of the test results and also take them through the limitations. So it is quite complex and it is important to take it on a case-to-case basis. That's my take.
Okay. Dr. Divya, did you have any thoughts on that?
Yeah, I mean, almost similar thoughts, case-to-case basis with no recommendations. Another thing, just between PGT-M and prenatal testing, actually, if the couple is already planning for an IVF and going for a PGT for another reason, I might err on the side of testing for PGT-M for an adult onset condition also, as it is a precious pregnancy. They want to do everything that they can, especially if there is a family history which is suggesting an earlier age of onset, an early adulthood onset. Then in those cases, like we did offer in a family for the family history had an 18-year-old developing breast cancer. And rightly so, the aunt, was very, very worried. And when she was already going for an IVF and everything, so and she was herself a carrier for BRCA. So we did, say to them that yes, it can be done. I mean, one could consider in such a scenario. So again, case to case basis.
Absolutely. And that's very true. I think case-to-case basis, these require a lot of insights and follow-up sessions with the family as well. Thank you so much to all of you for graciously accepting my invitation and also being here to share your thoughts and insights. These were very helpful. And I'd like to hand over to the Panjana, who will be moderating the next session.
Thank you very much, Neerja. Thank you, Nibi, and thank you, everybody.
Thank you, ma'am.
Thank you, Pratima ma'am. Thank you, Dr. Divya. Thank you, Nibi. And thank you, Neerja, for bringing up those questions. I welcome my panelists also right now. And we will be talking about fetal medicine itself. And there will be certain overlaps between what we do. But I would take up a case so that we identify with the situation and it will help us to answer them. So my panelists are Dr. Meenal Agarwal, ma'am. She's a clinical geneticist, Dr. Prasanna Roy, fetal medicine and gynecologist, and my friend and fellow GC, Miss Upasana Mukherjee, who was a genetic counselor. So is Prasanna here?
Yes, I'm there.
Okay. So we start with a case, and this case would be that we basically have a couple who is non-consanguineous. The first pregnancy resulted in anencephaly and a termination. And in the second one, there was a preterm birth at 5 months, and there was a neonatal demise. They did not survive. Before the couple planned the third pregnancy, the gynecologist from outside did WES carrier screening, and there was no pathogenic variants, and said to go ahead for their next pregnancy. And at 13 weeks, Dr. Prasanna, this couple lands up in your clinic, and the NT is 3.5, like above the 99th percentile. So the question to you would be, at the 13th week, when the NT was 3.5, the couple came back with a normal couple WES. Now, from the fetal medicine perspective, what would be your approach for surveillance and risk stratification at this point?
Thank you for the question. The NT is 3.5 at first trimester. So first of all, there is no role for screening. So any NT which is 3.5 or above, we will do direct invasive testing, and we will do a CVS for this patient. So we can see here that the nasal bone is normal and the NT is enlarged. So we will do stepwise testing for this fetus. We'll do stepwise testing. We'll do a CVS. We will plan for microarray, and we will counsel the patient that if the microarray comes out as normal, then they might have to go for an further exome. That is how we will approach this, provided that we have ruled out other cardiac and all other abnormalities.
Okay, thank you so much. So I will take this question forward to Meenal ma'am. So, sorry. So when faced with recurrent adverse pregnancy outcomes and early fetal red flags, what would be the most appropriate strategy? Like, should we offer a WES plus CNV, or should we go for a tiered approach, as Dr. Prasanna said right now? How should we deal with this?
Yeah, thanks, Deepanjana. I mean, first of all, I would go to your first slide where there was a history of anencephaly and neonatal demise, and the couple carrier screening was ordered. Before that, I would like also to do the karyotype, parental karyotype, because the chromosomal rearrangement will not be picked up in WES. So any child with malformation or any pregnancy with malformation, first we should rule out the chromosomal structural rearrangement, and then we jump onto the WES. Second, the maternal diabetes and anti-epileptic drugs, which may lead to a kind of a teratogenic effect, should be ruled out. Now, coming to this question. So I kind of agree with Dr. Prasanna. There has been two schools of thought, whether to do a CDS or to do an amniocentesis, and there has not any consensus. So if there is isolated NT abnormality at 13 weeks and the fetal medicine expert is inclining towards a CVS, I think tier-wise approach works better. First do a CMA because there is a higher chance of getting an abnormality. And if the abnormality is found, the discontinuation of pregnancy can be decided. If things are normal and the 16 weeks scan shows some or other variation or not, according to that, couple can be counseled about the risk of finding a genetic problem, which may range from 2 to 3% in isolated to maybe 8 to 10% or maybe more if this is combined with other structural variation. So both are combined depending upon the doctor's preference, the at gestational age when they have come, the presence of other markers or abnormality, and so on and so forth. But yes, in today's world where consumer reads and even the 1 to 2% risk appears higher, I would definitely like to go for an exome sequencing if NT, isolated NT more than 99 centile. At least provide an information.
Absolutely, ma'am. So, the point is well taken. So, I'll move on to Upasana Mukherjee. So, when you see that the couple has a normal carrier and yet, you come up with a case like this, how do you really frame the concept that a normal actually does not mean it's zero risk?
Thank you, Dipanjana, and thank you to ORDI for this opportunity today to come here. Well, this is a very common scenario when we talk about genetic counseling. You know, the most important part whenever we offer any kind of genetic testing, that has to be supported by a pre-test genetic counseling, because that is how we prepare the patient to understand what we are expecting out of a report. What does it mean if it is negative, or what does it mean when we see some kind of information is written, or maybe you can call it as a positive thing. So in this case, I think what we need to understand that not all the when we do a whole exome sequencing, that like a couple carrier screening, what the maybe the couple has gone undergone. So it is for only the monogenic conditions. It is for the gene defects we are checking. Now, in this particular case, I think I would like to take this case in this way that the increased NT is not always associated with a monogenic condition. It can be associated, as ma'am, my earlier speakers have already mentioned, it can be associated with certain kind of chromosomal abnormalities. And yes, before going for the couple carrier screening, we should have gone, like we should also go for a karyotype to understand whether there is a recurrence of any balance translocation is happening or not. So what I would like to highlight that this all information, what we do as the counselor, as a genetic counselor, as a geneticist, we prepare the patient to understand beforehand what we are expecting, so that it becomes easier when we are dealing with this kind of condition, that there is nothing found, but then we are finding something else in the child, or later on we expect any kind of de novo autosomal dominant cases are coming in. All those clinical and genetical technological aspects also.
Yeah, thank you so much for that insight. And we move on now. This particular fetal medicine specialist, they went for WES with CNV analysis, and this report also came up normal. But Dr. Prasanna, at 30 weeks, what you see is polyhydramnios, severe ventriculomegaly, and an IUGR. So the question to you would be that how would this change your diagnostic algorithm? We understand that all three exome sequencing, the couple and the fetus has come normal, and WES with CNV also has come normal. So how does it change your diagnostic algorithm? And at this point, is it too late for a meaningful termination?
No, it's never late for a termination, because since there is IUGR with polyhydramnios, that is a deadly combination, because IUGR does not go with polyhydramnios. So whenever we get IUGR with polyhydramnios, we are always worried that the fetus might be suffering from some kind of a genetic condition. So first of all, we will test the maternal torch. We will see that whether her IgM and IgG is showing any possibility of a torch infection or not. Because if that comes out as positive, then we will have to repeat the amnio and send for a torch PCR. And if that also is normal, then this WES might require a second look now. I mean, we might have to send a second sample to relook the whole exome sequencing reports. Because this combination is quite lethal, IUGR with
Yes.
polyhydramnios and ventriculomegaly. So it is definitely a syndromic fetus.
Prognostically, this does not put it well, even if the genetics is negative at this point. So, yes. So, my point right now would be to Dr. Upasana that so the couple has everything normal, but how do you counsel the patient? So they have done everything. So according to the couple, now would you actually ask for reevaluation as Dr. Prasanna was saying, or what would you like? What would you ask the couple to do? You are on mute. I can hear you from the
Yes.
next.
So sorry. So this is a very difficult situation, of course, with the couple and to handle this kind of sessions. First of all, since it is kind of the clinically it is right now, as Dr. Prasanna mentioned, it looks like a syndromic child with the presentation of polyhydramnios, IUGR, and ventriculomegaly. And I see the ventriculomegaly is bilateral and quite high. It's 18, I guess. So the prognostication, we understand it's not good, and this looks like a syndromic case. So I would definitely like ask the lab to reevaluate the cases, because in this case, many a time we know that we do not labs usually do not try to report any kind of insignificant, like a very rare vows, like the variant of uncertain significance is in the fetal cases. So that's one, the technical part. But yes, the counseling part is very important. We have to make sure that we give the empathetic support to the patient, telling them and making them understand that this is might be, as Dr. Prasanna said, it can be also the infectious reasons can be there, and there are a lot of diseases which are late onset, right? So which has now evaluated, and also we have to be very careful about the late termination facts also, if anything comes back. But keeping this thing in our mind, that whatever the parents ultimately wish to go for this pregnancy, that should be taken into the priority. You're on mute.
Yeah, so here what we wanted to actually highlight, and very rightly said so, that there are certain phenotypes which are evolving, and sometimes we might not find a genetic basis for that in the tests that have been done. So in this case, the reanalysis was asked, and the reanalysis along with the couple WES and the fetal WES yielded that there was a particular gene, the F8 gene, which is associated with fumarase deficiency, and two mutations were found. Both of them were a sort of VOUS, but if we understand that these VOUS, one had a Revel score of 0.7, another had a Revel score of 0.9, and because both the parents were also evaluated, we understand that this was in trans, that one came from the mother and one came from the father. If we look at whether this gene has any prenatal manifestations reported, yes, and it actually has a ventriculomegaly and IUGR which was reported. And this is basically a metabolic disorder, and in biallelic condition, neonatally, it causes severe neonatal encephalopathy, but it is still a VOUS. So hence my question to Meenal ma'am over here would be that the lab reanalysis say that it's a VOUS, and it's sort of a hot VOUS or a VOUSD. So why do early exomes frequently come back now? Like, can frequent like these kind of exomes, like you said that you have a conservative, like you might think that doing a tiered test is important, and why do these early exomes often come back normal? And is it a technical issue, or is it that depending because of the evolving fetal phenotype? Ma'am, Meenal ma'am.
Yeah. So I think here in this case, couple WES carrier was done pre-conception or early pregnancy. That was normal. And second, because of the increased NT, more than 99 centile WES was offered, and it was normal. And the FF gene, both being a missense VUS, were not matching with any of the phenotype or the presenting feature, both at the time of a carrier testing and at the time of NT evaluation. From a lab perspective, even if when we did the couple carrier, even if one variant was a definite PLP, probably lab today is in India and maybe globally, I'm not sure, they will choose to report it. Though there is no clinical correlation, but it is, if I would have been in their place, I would choose to report it. But if both are missense VUS in a gene, which has both dominant and recessive inheritance, and loss of function is usually means a frame shift variant, null variants are mostly the disease mechanism, probably I will not be the one who will report either in carrier or in the fetus. So the two limitations which can happen in a normal exome report and the evolving finding is one is a platform limitation. It is not covered, but most of it is not the case here. It is a variant prioritizing and reporting issue. And today is all over world globally, if a VUS, especially in both the variants, not matching with the phenotype, and even if partial matching, are not reported in any report. So this is a frequent limitations. And as the counseling goes, document, document, and document. Every time you counsel, document. At the time of carrier screening, at the time of NT, blah, 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 that this will not detect everything. There can be evolving anomalies.
Yes, thank you. And very important point, that document, like when you are giving a counseling note or when it is a clinical geneticist or a fetal medicine, please document that, everything is not being looked into and it is evolving, and there are even genes that are new, there are variants which are new, and we don't know what can happen. So, ma'am, did you want to add anything to that?
No, that is, document and keep a copy with yourself, because this goes long way and it will protect you all kind of medical, legal, and emotional complications later on. Document everything.
Yeah, that's exactly what my next question is. So the parents now charge that, why is this late variance detected? Why did the carrier screening not pick it up? And why are you saying it now? Because I did all the tests at the time when I could have taken a decision and I did not have to carry this pregnancy till 30 weeks. So you have missed something. Dr. Prasanna Roy, your take on this. How would you counsel
No,
them?
we will have to explain it to them that the genotype and the phenotype did not match during NT scan. It was only increased NT which the lab was evaluating. So they did not think it rational enough to report that VOUS. And now that there is ventriculomegaly and IUGR and polyhydramnios, that correlation might have prompted them to report this as VOS. So we will, of course, we will protect the clinician. There is no question about that. But the genotype-phenotype correlation has to be there for any VOUs to be reported. That is what I think. Did the same lab report this again?
Yes.
Okay, so they have a very good rationale that yes, they have not missed it previously also.
Yes, they have. So, yes. So then my second question goes to Dr. Meenal Agarwal, ma'am, again. Like, would you personally now, because there is a very strong genotype-phenotype association, and would you personally, if there is a fetal autopsy done or any other additional features there, would you personally like to sort of upgrade the variant? Because we get this question a lot from fetal medicine specialists as well, that would you, everything is matching, can we upgrade this?
Yeah, so it is a very tricky and very slippery slope. So missense. So categorically for all my GCs here, a missense VUS, especially a missense, where loss of function is a known mechanism, even if it is partially and vaguely matching with the phenotype, one should not upgrade a classification from VUS to PLP. It has to be a multidisciplinary approach, and we have to upgrade a variant no matter what, no matter how clinically strong I am. Objectively, the variant has to be upgraded to either P or LP with a multidisciplinary team or more evidence, like functional evidence, like autopsy findings, or something pathognomically, or some more reports. Before that, I would not really step into this slippery zone. This is a recipe for disaster.
Absolutely, ma'am. And my next question would be over here to Upasana. Now, there's three consecutive loss, and there's a lot of survivor guilt, grief, fatigue, and fear of recurrence, especially with, we are saying that, yes, there is something which is correlating, but what we can do is a provisional diagnosis. We cannot give you a diagnosis with certainty. So, in these cases, how would you counsel the family?
My first, I think our first approach is to make them understand the technology that what we are finding, like what is exactly the vows we are talking about and why we are calling them as vows. What I understand from my experience, the more information in a good way, not in a like a very difficult way, we provide to the patient and make them understand the technical part. That is sometimes that helps them to cope up with the situation. But they here, I think, since they have already lost the previous two pregnancies and it's now another pregnancy where there is no definitive diagnosis, and I think in these cases the late termination, Dr. Prasanna can add on if that is possible anymore. I do not think that would be possible also. So we
They have
will
to apply to the board.
sorry.
They have to apply to the board. If the board thinks that this is enough, I mean, proof for a late MTP, they can go ahead with it.
All right. So you mean to say that without the with the vows only because of the prognostication they can still do it, right?
So genetic report is not really essential for the termination. The prognostication is, as Dr. Prasanna over here said, that IUGR with polyhydramnios and a severe ventriculomegaly. Prognostically, this child, even with or without a genetic report, wouldn't do great. So, yeah, we can take it up with the medical board. The genetic report adds
Yeah.
on, but is not mandatory.
Right. So in this case, of course, this should be a multidisciplinary approach, like the thing we did right now, that understanding what is the prognostication and making the parents to understand, would be parents to understand what we are dealing with right now. And if whatever the decision is, if they decide to go on with the pregnancy, then to prepare them for the further newborn care right after the birth, what should be taken care of, and what are the precautions should be taken before choosing an hospital and all those things. And definitely there are a lot of psychological trauma right now, so if needed, a psycho evaluation and a psychologist support should be also offered in this case. Thank you.
Thank you for taking it up. So my final wrap up would be what we learned from this case would be basically the fetal phenotype evolves no matter how many tests we do. We need to counsel and document, as Dr. Meenal ma'am definitely said. As Dr. Prasanna also said, we need to have a better communication with the people to tell them what exactly we are looking at and why we are looking at and why these are changing. Communication is the key. Documentation is also the key, especially in fetal cases. And especially in fetal cases, when we are sending to the lab also has to understand that, that there will be variance, and it actually puts the lab and the fetal medicine and the clinicians in a very red zone. So that is why counseling and documentation is extremely important. And sometimes we might get surprises even after the child is born. So in some cases it comes earlier, some cases there are phenotypes that might not develop in the fetal stage also. So restraint in reporting is also something we need, so that we are not really taking a call for a fetus which is absolutely normal. And VOUSs are still treated as VOUSs, especially in the fetal scenario. So with this, our session ends. If there are questions, please drop it on. I thank my panelists, Dr. Prasanna Roy, Dr. Meenal ma'am, and Upasana for kindly agreeing in spite of their very busy schedule. And I hand over to Gayatri. Thank you, Gayatri.
Thank you.
Thank you, Dipanjana, and all the panelists. Yeah. Good afternoon, everyone. We now move on to the next panel discussion. Little Patients, Big Puzzles, the challenges of the unknown unknowns in pediatric genetics. With me, we have three expert panelists. Dr. Prashant Uttage, a pediatric neurologist from Uttage Child Neuro Clinic from Hyderabad. Dr. G.K. Madhavilata, Principal Genetic Counselor from Genome Labs Private Limited. and Mr. Suraj Manikandan, Senior Genetic Counselor and EC member of the Board of Genetic Counselling, India. We have a lot many genetic disorders that we know of, more than 8,000 genetic disorders that we know of, which has a spectrum of different phenotypes that is there, starting from developmental delay to short stature to systemic failure. On the other hand, we have different type of genetic tests that is available for their diagnosis. For certain disorders, it is straightforward. We have an algorithm. It's a single test, or for few, we require comprehensive testing. In this scenario, my first question is to Dr. Prashant. When there are overlapping clinical symptoms, which test do you prescribe? How willing are the parents to undergo multiple tests to reach an accurate diagnosis?
Hello all. If we take the example of pediatric neurology, it is a spectrum of disorder and it's more of a syndromic diagnosis in our case. Take an example of febrile seizure and followed by afebrile seizure during infancy, and then this child develops into the epilepsy. So we deal with developmental delay. That may be the global developmental delay, selective hypotonia, that is low tone, or maybe the spastic child, or maybe the autism symptoms, or the ADHD. Sometimes we come across neuromuscular also. So it is a spectrum, is very wide. But when we come across, what is important for any approach in a clinical setting, history, and history. So history gives us a clue. Like if you take the example of a child who has come during the infancy and child is completely hypotonic, weak, cry. So by seeing the child, there are differential diagnosis, maybe more. But when it is selectively hypotonia and child is less than 6 months or 1 year, then we selectively think of MLPA, like spinal SMN gene. If you take a child, same child presenting at, suppose different child presenting with difficulty, child was normal till 4.5 years, and then started difficulty in getting up from the sitting position or pain while walking, then we may think of Duchenne or BMD, and then again, we need to consider EMLPA. But when the same child of suppose 7 to 8 years and comes with febrile and afebrile seizure, and now the frequency has increased, then we need to see, are we dealing with any channelopathies or SCN mutation, KCNQ mutation? So selectively, we need to have the panel, that is the epilepsy panel, that is clinical exon sequencing. But when we come across a child with speech regression or autism feature hyperactivity, then we need to think in terms of whole exon sequencing. So everything depends upon the clinical history and clinical profile. And there are many tests, like if you take an example of Fragile X syndrome, so large head, large nose, and large testes, but this typically doesn't present. But any child with autism, a male child in India, we think of Fragile X. Although till now we have sent around 100 tests and not a single test positive for me in my child, any of my patient in India. And there are many things which are like child is dysmorphic, non-specific symptoms, and intellectual disability. I would rather think of chromosomal microarray. And if I am suspecting, like suppose child is obese, laughing, like take an example of Angelman Prader-Willi, and then I'll just particularly focus on methylation and UPD studies. So it's a profile. So we need to select according to the history and clinical examination.
The second part of the question, sir, how willing are parents to undergo multiple tests to reach an accurate diagnosis?
It depends upon, because I have worked in a clinical profile where I used to do the clinical history examination, make the diagnosis, counsel the parent for test. For the MRI, they already drain out by paying the fees. And then now they come to the genetic. But I have seen there is a great change in a shift in accepting the test by the parents. If you have the genetic counselor with you, and they properly explain how this test is important. The initial reaction, obviously, because of the financial constraint, they says we can't afford. But when we sit together along with GC and properly explain the parent what is the use if we diagnose. Then their question will be, is this going to save my child? Is this test is useful for this child? If second child, we don't want to go. But if we do the early diagnosis in a case of treatable epilepsy, like take an example of coenzyme Q deficiency, biotin deficiency. So what I show them, what are the few treatable genetic or metabolic condition, and then I started explaining. But if it is a complete clinical setting where clinician and genetic counselor is counseling them, finances won't be a problem, I feel so. So they accept it, provided you should give a proper time to them.
Yeah. Thank you, sir. Thank you for illustrating how genetic testing is important and how counselors make a difference in this role. While we understood there are so many different genetic tests available, also comes in a point where diagnostic yields are involved. So, with this in mind, my next question is to Dr. GK Madhavilata. Can you illustrate the diagnostic yield of comprehensive tests like whole exome and the chromosomal microarray? Why is a pre-test genetic counseling essential for these tests? And in the absence of Indian representation in the genome projects, how difficult it is to ascertain pathogenicity to the variant? Dr. Madhvi?
Gayatri, you are on mute.
Yeah. No. I was on mute. Sorry, I didn't find the. Yes. Sorry. Yeah. I'm back. Yeah. Okay. Thank you, Gayatri, and thank you, ORDI, for this, and Deepanjana to put up this. It's very beautiful. Okay. So now coming to the diagnostic yield, which is very important. We just finished Deepanjana's panel where Upasna and Dr. Prasna also discussed about how we have to tell them about why the results were we did not get an answer. So for that, as a GC or as a clinician, we need to keep this in mind. What is the diagnostic yield? So generally, as we know, for microarray, it is higher than the conventional karyotyping. So that's why for any kind of chromosomal aberrations, it is recommended. And the yield is generally often, it ranges from around 5 to 20%, definitely higher than the conventional karyotyping. But again, if for individuals, again, just like what sir was telling, if there is developmental delay and intellectual disability with autism, the yield is again frequently, it has been cited to be around 15 to 20%. So this is about the, so again, the clinical background or the indications play an important role here. So sometimes, yes, if it is like an isolated neurodevelopmental or only autism spectrum, sometimes even without an intellectual delay, then it is cited or reported to be 10% or even less, the yield for CMA. But when we come to whole exome sequencing, the diagnostic yield generally again is ranges and reported to be around to 25 to 40% with suspected genetic disorders, of course, yes. And the yields are often seen to be higher when the specific, based upon the specific disorder, okay. So, and if we combine in certain cases where again, whether it is in prenatal or in pediatric, if we combine and for certain reasons that both whole exome and CMA are suggested and recommended together, then often additional 30% of the cases actually where the CMA has come negative, the whole exome sequencing has actually given an answer. So this is something that has been reported till now across the globe from different individuals. And what was your second question? Yeah, how is pre-test, very important. So pre-test GC is important because keeping this in mind, it helps the family to actually understand what is it that they are going to do, what this test is going to tell them, what it is not going to tell them. So understanding the implications, the risks, and we would very clearly explain to them what would be the possible outcomes of this particular testing, so they can take a proper decision and also prepare themselves. So depending upon what is the stage at which the test is being done, just like sir was telling, when we counsel them, when in a pre-test counseling itself, we can tell them they can choose to do the tests together or do them one after the other, depending upon the cost or what is the yield at the based upon the clinical details currently available, so that the parents can take a call, and all this would be very important, or it would be possible only if we have a proper pre-test GC with the clinical indications. And you had a third question, right? Yeah. So yes, so in the how difficult is it to ascertain a pathogenicity of a variant? Now, of course, now when you talk about pathogenicity of a variant, of course, it is, there are lots of factors that, the analyst actually goes around. So looking first into, very important, again, the previous panel has given me a very good point, that clinical indications are the important, basis to see or even pick up a variant. So the clinical details are very important. And once you have the clinical details, you need to have what kind of variants, what is the biological evidence, functional evidence, experimental evidence that is available for these variants. What do we know about the type of variants already reported for this particular gene, the type of inheritance, whether both ADR are there, or it is most of the time, is it only missense or a combination of both missense and nonsense variant, and all these things. And for example, in some of the genes, as we all know, both loss of function and gain of functions have been reported to cause different type of phenotypes also, right? So finally, it comes to I think that it is about the clinical details that we have with us. And of course, all other things put together, it would decide. But when you ask about the databases and how it would help, yes, definitely. Now, all the companies have, their own internal databases, which are quite good. That's one. Second, again, I'm happy that, after you gave me this question, I was going through the Indian database, that the Genome India database. So we discussed that it was 10,000, but I saw that it is actually 20,000 samples have been collected, but only for 10,000, the data is actually ready, and they may be releasing sometime in 2026. So I think more such, if we have these databases, it would help us to, maybe filter out certain common ones, or to even pick up rare variants, both that are very specific to our population. Okay, thank you.
Thank you, Dr. Madhavi. Now that we understand the complexity of genetic testing and reporting, we realize that no genetic test would have an 100% diagnostic yield. With this in context, we move on to the next question to Mr. Suraj Manikandan. What are the challenges you come across in communicating reports with inconsequential genetic test reports or variants of uncertain significance, especially in a family desiring to plan another pregnancy? Part of this is already taken by Upasana, but we would like to have your perspectives on this.
Thank you, Gayatri, for inviting me to this session today. And also, I take this opportunity to wish everyone my appreciations for Genetic Counselors, Awareness Month. All of you are doing a wonderful job, including the geneticists and our other kind genetics professionals taking up this tough task of genetic counseling. I hope I am audible, clear, Gayatri?
Yes.
Yes. So to take up this question, what defines an inconsequential genetic test report really means it means the presentation and the clinical corroboration. Madhavi actually alluded to this. Pre-test genetic counseling is very, very important because these days in times of whole exome and genome sequencing, we get to see a lot of unexpected results in the report. So it is very essential to talk to parents about what would be the components of your genetic test report, such as the primary findings that is associated with whatever is the clinical presentation. And there are secondary findings which the parents may deny or accept. Since this is pediatric setting, I'm mentioning it as parents. This is applicable even in the adult setting. And the other findings like carrier statuses and other findings that may or may not be related. These are different components. But then we would also tell them that even your primary finding may have an inconclusive result, which is variants of uncertain significance because some of the symptoms might be associated with that condition. So in India especially, we do not many a times have the luxury of having the families and parents in front of you for post-test counseling with a thorough pre-test counseling. If it was done thoroughly, then that's a luxury in an ideal case. Otherwise, we'll have to explain then what it is. So how I would put it is that if at all you get a VUSS, what makes it inconsequential? Who would decide it? Madhavi had put it across nicely what all the lab does to, report a variant. But as a genetic counselor or a genetics professional, I would myself sit to work on to understand what that variant is, what is the current status of that variant, and how is it clinically corroborating with the presenting symptoms in this case. So if you're confident that this is associated with it, then you consider that. Other than these are inconsequential, that may or may not be related to what is presenting in the child. So I have had cases in the past where you have got, for many patients, multiple such uncertain significance, variants of uncertain significance. You would have to explain to the parents that when we all do genetic testing, when we look at our report, we would have at least 3 to 4 variants of uncertain significances. So I would try to normalize this first, that not all variants of uncertain significances are, have deleterious effects, or it may or may not be related to the presenting symptoms. So this way I would normalize it a bit so that they are not, alarmed looking at the results that I have got so many things. Most of it might be inconsequential. Yeah. So one example that I would like to quote is that I had seen a couple in the same scenario, very rare neurodevelopmental disorder having multiple uncertain significance, and we cannot say inconsequential, some overlapping symptoms presented, and they were in front of us with the report. So we had to, and they were planning pregnancy like in this scenario. So we had to explain them and then slowly dissect all those variants of uncertain significance by doing further analysis. And they had to plan pregnancy as well. So you cannot stop them when you do not have an answer. So we explain them about the uncertainties, yet we told them that the recurrence risk cannot be precisely predicted in this case, and it not necessarily you might have the same problem recurring. So they understood and the balanced approach, and then they did plan pregnancy, and then they had a wonderful second child. At the end of the delivery of the second child, they also got the results of the analysis of the first child with a new condition that was identified in 2024.
Thank you, Suraj. Now that we understand there are different genetic tests and each one has its own complexity, we would like to go back to Dr. Prashant and ask why molecular diagnosis is still important. It's essential for treatment and targeted management of genetic disorders, and how many of the genetic disorders have a targeted treatment? In 2021, the National Rare Disorder Policy was released, and we want to understand how many children have been benefited by these who have a confirmed diagnosis.
So to answer your first question, why the molecular diagnosis is essential? Obviously, to pinpoint exact genetic cause, we need this molecular diagnosis. Take an example of SMN gene. Even DMD, initially there was no treatment at all. But if you see now, there is a treatment hope available for a disorder like SMN gene. So pinpoint diagnosis, genetic diagnosis is very important. And obviously, once you diagnose the pinpoint diagnosis is the precise treatment, including the gene therapy, exon skipping, enzyme replacement therapy, and targeted drug treatments are available. And it gives the misdiagnosis. If you see the recent paper published by Dr. Mahesh Kamte from Belgaum, there is around 74% of cerebral palsy cases out of 250 were diagnosed as a genetic cases. Means it was like a known case of cerebral palsy. It has to be written in every case sheet. But when the retrospectively studied the cerebral palsy cases around 250, 74% turn out to be something different and diagnosis. So pinpoint diagnosis is very important. Like if you take an example of Leishman syndrome, if it has not been diagnosed early, that one child we can prevent from becoming one cerebral palsy or dystonic cerebral palsy. So pinpoint diagnosis is just diet modification and simple allopurinol will prevent that condition. And obviously for the family planning and prenatal testing and carrier detection, it's it's very important. Now, how many genetic disorders have been targeted treatment? So according to the FDA, most of the rare diseases do not have the approved treatment, but according to the National Organization for Rare Disorder, that is NORD, in 2021, around 564 treatments were approved to treat 838 rare conditions. So this is exact number. But as of now, approximately there are around 550 unique orphan drugs approved for 1100 plus rare disease indication. But these are like orphan drugs, not particularly so these are the exact figure for this rare disorders. And moving towards the how has the this national rare disorder policy. You want me to tell detailed policy also? It's like
No, sir. A quick brief would be helpful.
yeah, okay. So, National Rare Disease NRDP 2021 benefited children has helped the children and families through the financial support, especially 50 lakh rupees for one-time curative treatment. And Center of Excellence offering specialized diagnosis and care has been approved, and faster and early diagnosis with focus on molecular testing and newborn screening has been approved, and better access to enzyme replacement therapy, stem cell therapy and dietary therapy and genetic confirmation has been.
Yeah. Thank you, sir, for explaining why genetic diagnosis is important and how about 10% of the rare disorders have a treatment today. Moving on, our next question is to Dr. Madhvi. What is the pathway or process for a novel genetic variant to be associated with a disease, and why functional studies is increasingly important in pediatric and prenatal context? How can genetic counselors contribute to this process?
When we talk about a pathway or a process for a novel genetic variant, so it is actually a multi-step process. We would know as scientists and geneticists. So it's a multi-step process that combines, you have a genetic variant identified first. Then there should be a statistical genetic evidence for that particular variant. And then you would want to have a functional data. But of course, even the point of first identifying the variation itself would start with clinical observations. So something like doing a GWAS studies. So you're having the combination of clinical observations and identifying a particular variant in all these people. So identifying and annotating it, and then associating it with statistically with all these findings, and then if possible do a functional characterization. Generally, I mean, initially you would not go for, definitely we would want an in vitro or in vivo studies. But at least the first step would be in the lab itself, where the in silico analysis, where there are lots of these prediction tools available, what we generally know about this group of genes or the genes that come under a particular pathway, right? So all of these would be looked into, analyze them and do certain in vitro, in vivo studies, and then re-look again into the evidence with all of the information available. And of course, before finally telling that a particular variant is actually pathogenic, you would want to replicate it again. That is, it is really observed in many other in different places altogether. So generally, this is how it is actually followed. But in these, for such kind of studies, you say, why are functional studies very important, and why are they important specifically in this particular question, where we want to know in both pediatric and prenatal context is it would, as sir was telling, first thing is it would avoid misdiagnosis. It would increase the diagnosis, efficiency. And in cases where they can take a proper treatment decision, it would help a lot for them if you have a very good answer. So even like, for example, now the terms that are being used, like even 5 years, not all of us were using these terms like hot and cold, right? So even that also actually helps if you are able to give some answer to the clinician or to the researcher who's even developing certain kind of treatment modalities. And for all of this, your important question of this whole three-part question is, how do genetic counselors and how can they contribute in this process? Actually, I think we do play and we should play a very important role if involved from step one itself, where the genetic counselor would facilitate in data collection, maintain the records, and answering the ethical questions from point one, from day one onwards, and then promote the research collaboration. Keep even the parents or the families involved, the doctors, everybody put together, involve them, and then so that everybody is in line, speaking the same language. So all of this, in most of these, we would act as a bridge here, where we would help and facilitate this, the research. So that is what I think that we would play very important role. Okay.
Thank you, Dr. Madhavi, for illustrating how genetic counselors could play a cohesive role in accelerating the research in genetic disorders. Our last question is to Suraj. I would request to wrap up in 2 minutes. The question is, with your extensive experience in the community genetic counseling setup, how does a genetic counselor cultivate a mindful practice to ensure inclusivity yet confidentiality, spread awareness yet prevent stigmatization in group counseling?
It is such a big thing to discuss, and you're asking me to wrap up in 2 minutes. I'll try my best, Gayatri. So there are two things when we call it a group genetic counseling for a bigger forum, like discussing common things like what is the condition about and all that is I would say it is a genetic education. So what do you call a group genetic counseling or a family discussion group is that you systematically plan a set of families. Each and every family, you should study very carefully the history of the condition, the presentation, what stage the family is in. For example, in DMD, you can call families together who have inheritance risk, children who are ambulant, children who are non-ambulant separately, mothers who are carriers. So you separate groups and then design your family discussion group so that you could specifically discuss on the issues with that particular group. For example, in cancers, you can pool together breast cancer cases where there are inheritance risks high, multiple family members affected, and there are a lot of studies that had done grouping multiple cancers together. So everything is a unique approach, and we have to study the families well in detail. I just have to say one point. I had an opportunity to work in the public health setting. When you talk about confidentiality and privacy in public community settings, that's very hard to get. So maximum what I would do is that keep a registration on, nobody other than the family members enter the premises, have a considerable distance between the individual counseling desk and where the patients wait, if you do not have private rooms and all that. All these are aspects that I would be mindful to, preserve the confidentiality of the family members. Thank you.
Thank you, Suraj, and I thank all the panelists for the wonderful session.